Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Procedures in Hospital Dentistry with Dr. James R. Hayward, Professor of Oral Surgery and Director of the Department of Oral Surgery.
While practicing in the community that he serves, the dentist may be called upon to treat patients within the hospital. Most dental education does not include a great deal of exposure to the hospital environment. As a consequence, it is well for a dentist who will be called upon either to take patients who have particular problems into the hospital or to serve patients in the hospital that are there for other reasons. It's well for him to become acquainted with the protocol and the facilities and to establish a membership on the hospital staff. Before he does this, he will quite naturally familiarize himself with other staff members on the hospital and spend some time in the hospital operating rooms and clinics so that he can become familiar with these elements of the environment. It will be important for him to make formal application to the hospital, and when he has done this and when he has been accepted as a member on the staff, then he will be able to admit patients to this hospital. Now, it is our purpose today to bring to you certain of the procedures that the dentist will follow upon admitting his first patient to the hospital in order that he may fall into the mainstream of hospital management of patients and consequently perform efficiently. So with this in mind, we would like to bring to you today a few of these procedures that the dentist will follow while serving patients in the hospital. Among the things to consider is the admission of the patient. As the patient is admitted to the hospital, he needs a note from the dentist indicating the diagnosis, the estimated length of stay, and the procedure that's planned for that admission. This will have accompanied the patient then to the hospital where he becomes registered. Today we have Dr. McGuire with us, who is volunteered to act as our patient here at Bedside, so that we can bring to you a few of these elements of a preoperative visit. As the patient is admitted to the hospital, he is assigned a registration number. This number appears thereafter on all records that pertain to that patient and his hospitalization. It's important for the dentist to realize as he fits himself into this complex of the hospital where his responsibilities will lie, who he should look to for assistance, and in general integrate this for the better care of his patient wherever possible. So the patient will have a record, and this is an example of the hospital record, which contains all of the data relating to the patient's care. We will have here a front sheet which has the patient's name and other identification data upon it, a place for some diagnoses and procedures that are final in scope. And although they vary in the way in which they appear, the color of the paper and the coding that may vary from one institution to the next, charts in general contain basic areas of the evaluation of the patient by history and examination, by laboratory determinations and X-ray reports, and will also contain an area for the notes of the people that attend this patient, the nursing notes, and the place for regular recording of data regarding the patient's stay. For example, every chart has a graph on it of this sort, which includes the day-to-day recording of the patient's temperature, his pulse and respirations as they are observed from intervals of 4 to 8 hours, depending upon what the orders may be for that patient. There's usually also a section for medications summarizing the medications that the patient may be on and the time intervals at which they are administered. These are some of the places in the chart. Here we would have sometimes forms are used for recordings of history and examination. Other instances, there are the usual segments of a chief complaint, a present illness, past history, a systemic review, social history, and other things, that information that the patient gives the examiner at the time of the history recording. Then the examination findings appear, and finally a diagnosis and a treatment program. In this section of the chart that contains laboratory data, there will be separate slips for different elements. There will be records for urinalysis, records for hematology, records for serum chemistries. Here, for example, is the hematology determination and report on this patient, which includes a 13-gram hemoglobin, a normal hematocrit, a 10,000 white count that's not particularly remarkable, and we'll have these data then available. It's a good idea when you are reviewing some of these laboratory determinations, that some of which may have been requested by colleague physicians, to carry with you a simple reference of normal findings, so that you can have a simple determination available to compare the laboratory data with known ranges of normal. This is helpful since you often cannot carry all of these levels of quantities in your head for serum chemistries and electrolytes and other things that you may not be using every day. At any rate, one of the aspects of the preoperative perusal of this chart is to make sure that any abnormality has been detected and that appropriate consultation has been sought, so that this patient's care will be as satisfactory as possible. Now, the patient will get no care at all unless you order it. And this brings us to the question of patient orders. The orders on a patient must include some general and then some specific items insofar as drugs that are administered for their care and the like. Now, orders are recorded sometimes directly on the chart, in which you will find a special sheet for orders. In other institutions, such as our own, they appear in an order book, which is kept at the nursing station, and in which the patient's orders can be identified. There'll be a stamp at the top identifying this patient specifically, and columns for entries of the date, hour, and the numerical sequence of the orders which you write for the patient. I must emphasize that he'll get nothing. He won't even get his lunch or breakfast unless you have ordered the specific diet that he has. He'll get nothing for pain control. Nothing is considered automatic in the hospital. You must write these orders, and they will include all those things that pertain to your diagnosis and treatment. So there'll be an order for a diet, whether it be general or a specialized diet, an order for analgesics that will take care of pain problems, orders that otherwise relate to the diagnosis, all these things for patient care, something for sleep at night, all these things that are general in nature will be recorded. If you want to record intake and output of fluids in certain diagnoses, this is, of course, is vital. If the patient's been injured and you want vital signs recorded, you have to order them. Anything that you want to have done has to be written as an order. Nothing can be considered as automatic. Also, in this situation, you will be writing orders for narcotics. If you write a narcotic order, it's good only for a limited period of time, and then must be rewritten. The orders that you write for general care must be considered, and then there will be preoperative orders as well. Now, we've covered the fact that orders must be written for the patient, that significant and salient data are recorded on the record, and that one of the purposes in your preoperative visit to this patient is to review the record, to see what has been recorded in the nature of a physical examination, which must be recorded by a physician member of the staff, pick up any abnormal findings that he has noted, and see how that may alter your treatment plan. There may be additional consultations that are required. You review the laboratory data. You review the chest x-ray and make sure that that is satisfactory and that he's a candidate for general anesthesia on those several scores. We'll talk about an operating permit in just a few minutes, but one of the things that you will also do here in this time is to reevaluate your patient. Your first approach to the patient is, of course, a comment on their welfare. We ask them how they're feeling, if they have any needs that have not been met, if they have any pain, what to do about it, what to ask for, how to call for nursing assistance, these things that relate to his general well-being and a feeling that he's not lost in the shuffle in the large institution of the hospital where he's seeing lots of new faces and routines are going on around him that he doesn't understand. We take time to explain these situations to the patient, and then we will check immediately on the condition for which he's admitted and repeat our examination of the mouth and jaws. So I'm about to do that for the moment to demonstrate bedside examination of the oral cavity. And because this necessitates retraction of lips, sometimes patients' lips dry out, and we suggest that they lubricate the corners of their mouth and their lips with some Vaseline or similar lubricant before the examination. And of course, before we examine this patient, we are going to wash. Cross-contamination within a hospital is a very important concern, and the problem of spreading infection from one patient to another is highly significant. So you, as a member of this dental staff, have arrived. You're in your coat that's the uniform of that hospital. You have your equipment of a pen light and some tongue blades here for this examination, and you'll prepare your hands in the closest washing facility that may be present. Here we will have a wash basin, and we'll prepare our hands before we go to the examination of the patient that will include inspection and palpation of the oral region. Now, you probably have examined this patient before. You know, at least we hope you have. If you've admitted him to the hospital, you know the condition. Nevertheless, it is advisable to repeat that examination and make a detailed entry of your findings on the record before surgery is carried out. And this is one of the purposes then, in addition to reassuring the patient that you are certainly up to date on precisely what their problem is and what needs to be done about it. Most of these washing facilities will have a foot pedal or knee control or some way in which you can shut them off without contaminating your hands again. So we will return to the patient, and for the purpose of this examination we will use a tongue blade. Tongue blades frequently can be wrapped in this fashion so that they are sterilized and individualized, so there's no contamination of them. The pen light that we use as a source of illumination to help our examination is a simple source of light. So we will go through a few aspects of examination, and as we look at Dr. McGuire's mouth here for a moment, we see his lips in repose. We examine them and ask him to open his mouth widely and check for any deviations of the mandible. We then will ask him to protrude his tongue and note any deviations in that organ. And then we'll begin our inspection of the oral cavity in a logical, stepwise sequence, beginning with the lips, and then the buccal mucosa and the palate, just as we go through here, then examining the vestibule of the mouth, the inner aspect of the lip, the buccal mucosa, the parotid duct orifice, the superior vestibule, inner aspect of the upper lip. We'll ask him to close, just bite down, noting the occlusion. Now open again. We'll examine the palate. We'll examine the pharynx. We'll ask him with his mouth open to lift the tongue to touch the roof of the mouth so that we can examine the important and often neglected ventral surface of the tongue, examine the orifices of the submaxillary ducts. And in this quick surveillance, we have looked around at all, all the mucosal surfaces, and we would then proceed with palpation. Now, in palpation of the lips, we prefer to grasp the lip between thumb and finger, and with bimanual palpation proceed to examine the cheek, and then the palate, the hard and the soft palate, the dorsum of the tongue. Frequently we can do this by asking the patient to protrude the tongue, grasp the tip of the tongue, retract it to one side, examine the lateral border, and gently palpate the surfaces of the tongue. Well, with this, then, we have palpated carefully all of the interior of the oral cavity, and we will finally finish up by a palpation of the floor of the mouth bimanually, and palpate the regional cervical lymph nodes, submental, submaxillary, and the cervical chain. Any abnormalities then that are up to date in the immediate preoperative phase we now are aware of. So we will next return and wash our hands before we record the findings of this immediate preoperative examination. If we have any abnormalities that are picked up that will tend to postpone the procedure, we certainly must efficiently try to resolve these just as promptly as possible. We will want to have then preoperative orders to consider, and preoperative orders will include those things that are necessary for the anesthetic, namely there will be no food or no fluids that are taken in at least 8 hours before the operation, and additional medications that relate to the pre-anesthetic condition, such as a belladonna drug for drying purposes, a hypnotic as a pre-anesthetic medication. These are some of the preoperative orders then that will be written, and these preoperative orders then cancel everything that has been written before, and will return to a postoperative visit consideration later on for that, to describe that. I would like, as we now would at this stage be recording our findings on this examination, we reach a phase in which we would like to have the operating permit signed, another of the preoperative considerations and prerequisites. The operating permit is an agreement on the part of the patient to have necessary surgery and anesthesia performed. It has several different statements that are provincial to the institution. This particular one grants permission to your surgeons for any operation or any anesthetic that is necessary, which at any time in their judgment seems to be in my best interests. And then this is dated, signed by the patient. When we ask to sign this, ask him first if he has any questions, and we want to be sure that he understands fully what will be done, and if there are any, this is the time in which those possible misunderstandings are completely eliminated and resolved. This then is also dated and witnessed, usually by a nurse or another attendant. So the patient then will sign this operating permit. Now we've tried here to outline for you a few of the essentials in the preoperative visit to the patient in the hospital. Certainly you want to reassure this patient that everything will be done for them to be sure that the utmost safety is followed in their care, so that their ultimate welfare in attending to this disease or problem of their mouth and jaws is resolved. This is the time to ask questions and suggest to your patient that if they have any questions, you'd like to know about it now. Dr. McGuire, in your workup of patients on the floors of the hospital, do you recall any appropriate questions that arise at this time?
Patients like to know how long they'll be in the hospital and how long it will be before they might get dentures after extractions, or how their eating habits will be affected after the anesthesia?
These areas for the total care should be considered. You can estimate the duration of the hospital stay. You can particularly inform the patient about what they will experience both in going to the operating room and immediately upon awakening from the anesthetic. And this is important, informing them that they'll feel a little groggy perhaps going down to the operating room. They may have then a shot in the arm while they drift off for their sleep. And when they wake up, they will be in a recovery room area, and they may have a little sore throat and a sore mouth or whatever you've done for them. They will have some symptoms of that nature. They can ask for something for discomfort, for relief of pain if they have any pain at that time, just so they know in advance exactly what they can expect in the environmental changes and the sequence of events that they're about to go through. Now, insofar as further questions about stay in hospital and other elements of care, these things can be resolved. Medications that the patient's on concurrently may come up. And in general, I can tell you that it's important that you write and prescribe everything that relates to the care of the mouth and jaw region that you have responsibility for, and that you see that their medical needs are attended. If they have cardiovascular disease or diabetes or something like this requiring digitalis or insulin or something of that nature, make sure that a qualified medical consultant writes those orders for you. You write the orders that relate to general care and to the specific needs of the oral disease, and rely on your colleagues for these other areas. So with that, we hope that we have our patient ready for surgery, and that he'll be comfortable, and we give him all the reassurance that we can that it will be a smooth go.
Thank you, Doctor.
In order to prepare for the entrance to the operating room, it is necessary at the doctor's lounge to appropriately put on the customary garb, which is a scrub suit attire. And Dr. Bonnet here has put his street clothes in the locker and has put on this freshly laundered scrub shirt and scrub pants. And he will now proceed to put on a cap and mask and shoe covers for his approach to the operating room. The cap, appropriately contoured, is tied in the rear and keeps the hair confined, avoiding any possible contamination dropping from the scalp in the operating room. This is tied securely, and he then will proceed with putting on the mask. Masks may be of different varieties. This one is a disposable mask. It has on its upper border a small wire that contours to the nose rather well. The four tails tie, one above the ear, high and on the above the occiput, and the other one low on the neck. For those who wear glasses, this contouring is important, and if there is no wire in the mask, then a piece of tape can be placed, as Dr. Bonnet is showing now. A short piece of tape can be used to secure the upper edge of the mask to the face so that the exhaled air will not be expelled up under the spectacles to cause fogging of the glasses during the operation. With this, we'll then turn to shoe covers, which are an important aspect of apparel and entrance to the operating room area. Shoe covers perform two services, fundamentally: cleanliness and safety. Cleanliness in protecting the operating room area from street dirt. Conductivity, provided by the conductive rubber sole and the strap that you see here, extending from it, in order to avoid the buildup of static electricity as an explosion hazard in the operating room. Dr. Bonnet then is putting on this shoe cover securely. He takes the conductive strap next, and this can be placed in either of two areas. We prefer to place it, as he's showing now, tucking it down underneath the sock and under the edge of the shoe where it's held securely in contact with skin. Then he will cross the straps of the shoe cover and tie it in front so that this securely holds the strap against the ankle skin. The strap can also be placed between the shoe and sock, but if the socks are insulating, this does not give us the good contact that we need. One needs contact for electrical conductivity from skin surface to the floor. This drains off any static charge from the personnel that are circulating in the operating room off to the conductive flooring in the operating room. To be sure that this conductivity feature is functioning, there are testing devices, small machines, battery operated, in which one foot is placed on each of these two plates on the pedestal, and a switch is turned in order to determine whether or not conductivity has been assured. Dr. Barnett will demonstrate this indicator of this machine as he places his foot across the plates. You can see that as the test switch is turned, that a satisfactory level of conductivity is registered. With those aspects of preparation established, he then will remove his jewelry, stripping his watch and any rings, and put his valuables, his wallet, in the pocket of his scrub suit. And he then is ready to proceed to the operating room area and to proceed with scrubbing before entrance into the operating room. On the morning of surgery, the premedicated patient has arrived in the operating room, and the doctor brings in any extra instruments that he needs for this particular case that the operating room may not have as standard instruments. The charge nurse or circulating nurse takes these instruments and autoclaves them, adding them to the case preparations. The doctor reassures the patient in regard to the anesthetic and what will take place, and then proceeds to the scrub room. In the operating room, x-rays are available for the operation and can be referred to readily for the requirements of the procedure. After completing his arrangements in the operating room, Dr. Barnett enters the scrub area in order to proceed with the preparation of his hands and the standard scrub-in procedure before entrance to the operating room. Dr. Shewan has just completed his scrub, and he is leaving. Dr. Barnett approaches the scrub sink, which is controlled, the water flow controlled by the foot pedal on the right, and the soap or surgical soap, hexachlorophene containing surgical soap, by the foot pedal on the left. Dr. Barnett then will proceed with this scrub-in, which will be for a full 6 minutes. He, first of all, will lather his hands thoroughly and proceed with the lathering up to and including the wrists and forearms to the elbow, but not including the elbow. The main objective of this scrub procedure is, of course, to remove bacteria from the skin surface and to particularly prepare the hands. So at no time will he touch any object during this procedure, and the rinse that he carries out will rinse the soap from the hand, and the drainage will be down the forearm and off of the elbow so that there is no backflow from the elbow to the hands. He is rinsed thoroughly and will now direct his attention after the first scrubbing to his fingernails and cuticle. He's been working on the inaccessible areas of his hand as well. He takes this autoclaved orange wood stick that he got from an autoclaved container in the shelf, and he now proceeds around the cuticle and under the fingernails to thoroughly manipulate all dirt and debris from these surfaces, which otherwise would tend to harbor bacteria. His efforts now with the Physahex are carried out on both hands in these inaccessible regions. As this orange wood stick is used to move the hexachlorophene soap through these areas, a thorough rinse off will then follow, and the orange wood stick is discarded without touching anything, you notice, just discarded into the container there, waste container, and he'll rinse off and continue with this series of lathering and thorough, vigorous manipulation of the skin, working up a thorough lather and working the lather into the inaccessible places between the fingers and on the back surfaces of the hands, the places where ordinarily one in simple washing of the hands doesn't consider. This then is a thorough procedure which he will continue for 2 more series at least of latherings, each time doing the hands, and from this point forward he doesn't go up beyond the wrist, he doesn't go up to the elbow again, but stays with the hands, letting things run off in that manner. Each time draining, as you see, and being careful at no time to touch anything. If he should accidentally touch the faucet or the sink, it would be necessary for him to begin his scrub procedure entirely anew. So he'll continue this for 2 more series of lathering and rinsing. While Dr. Barnett is scrubbing, the patient has been anesthetized, the induction has been completed, and a nasal endotracheal tube has been passed. Dr. Bruce is applying a tape over the eyelids to keep the eyelids closed during the course of the preparation of the field and the course of the anesthesia for protection of the cornea. The patient then intubated, is exchanging satisfactorily, and is now ready for the preparation of the operating field. The preparation of the operating field for dental procedures varies considerably depending upon the type of procedure. We will demonstrate here the usual and expected preparation. Dr. Shewan has scrubbed the routine 6 minutes and is now drying his hands. He will discard the towel and will proceed. You can see that he has dried first one hand and the other and dries only the hand and wrists, discards the towel, and proceeds to pick up the gloves. He picks up the gloves in a manner that only contacts the inside of the glove surface and puts on 1 glove at a time, being careful to not contaminate the external surface. And his hands now are gloved, and he'll proceed with the preparation of the operating field. This is done with a number of agents. The usual sequence is hexachlorophene or Physohex or similar surgical soap, which will, with thorough mechanical cleansing, repeatedly prepare the skin surface and mucosal surfaces. He has a dry sponge in his left hand and a moist one in his right, and he will use the dry sponge once again to avoid the ingress of any of the preparation materials underneath the taped lids to irritate the eyes. The preparation is done by beginning at the target area and then proceeding from the central zone peripherally with each of the sequences of application and scrubbing with the surgical soap going out then to the periphery. These are intermittently wiped off then and dried so that a series of applications takes place in the field that will remain sterile. This may be followed by iodine preparations such as betadine or other, in certain instances, other chemical solutions for further preparation of the skin. In this manner, then, the total field will be prepared. In each instance, the operator who is preparing the field is careful, of course, to work from a central area out and to avoid going back in again to possibly bring contaminants back into the field in which there's the greatest interest. After the vigorous preparation of the field, then this will bring us to a point where the next stage will be the draping of the patient, and the preparation then we will consider now completed. While Dr. Schuon has been preparing the patient, Dr. Bonnet is completing his scrub procedure and has about finished his 6 minutes of hand preparation, having gone through this sequence of the initial preparation of the hands and arms, the attention to the nails, the thorough and frequent repeated lathering and rinsing, and now is finished. He will conclude by again rinsing the hands thoroughly. In some institutions this is followed by alcohol or other chemical rinses prior to the entrance, but you notice he holds his hands up high. He does not dry them with anything. They're just air dried, and he keeps them well in front of him so that as he now leaves to enter the adjacent operating room, his hands are in front of him, and he will now go into the operating room. After completing his scrub procedure, Dr. Bonnet enters the operating room with his hands held high and is given a towel by the scrub nurse. He carefully dries his hands individually, being careful to keep the towel away from other parts of his body. He dries only the upper part of his hands and wrists and is presented his operating gown. The inside of the gown is toward him, and he seeks out the armholes, and he is helped into the gown by the charge nurse or circulating nurse, Miss Powers, who will help him to get tied up. There are ties and clips on the back of the gown. He's very careful to keep his hands away from the rest of the gown surface and to keep the cuffs of his gown down well on his wrists as he prepares to be gloved. As he is gloved by the scrub nurse, she presents him with the left glove first. The thumb is toward him, and she helps him into the gloves, being very careful not to touch her as he gets into this gloved area. This is a special wraparound gown which enables the gown to give us a covered surface on the back side, so that that area that was tied by the circulating nurse will not be contaminated, and he therefore is covered both front and back by a sterile gown surface. He then will approach with the scrub nurse the area of the operating room for draping, and on the back table the drapes have come out of a sterile pack, and he's presented with a squared draw sheet and 2 head towels that will be used in the draping. The anesthetist is raising the patient's head, and Dr. Barnett is careful not to contaminate his gloves or gown as he applies these drapes to the field. He then takes a towel clip, and being careful to insert this away from the patient's eyes and other areas, he holds that head towel. He then applies other cuffed towels which supply 2 thicknesses of sterile linen to the periphery of the prepared field. This then, around the entire parameters of the operating field, gives us the protection that is needed with the 2 thicknesses of sterile linen. These then are cuffed towels, and towel clips are being used to secure them. The entire table surface must be similarly protected, and to do this, a draw sheet of special 2-thickness type. This is called an oral sheet, and there is an opening that will spread then around the head, and you notice the manner in which the drape is folded, so that carefully as it's unfolded, it will provide a complete coverage of the entire area. This then is also secured, and we have then the draping of the patient, the isolation of the prepared field, and the entire table covered. The Mayo stand is moved in, and this supplies the individual instruments for the given case. The suction tubing is brought up and is secured to the table linen. This is a pharyngeal suction tube used to clear the pharynx, and one of the first steps that will be carried out is suctioning of the pharynx and the introduction often of a pack into the pharyngeal region. The pack usually can be a moistened 4x8 gauze, which can then be placed in position with a tongue blade, which you can see being inserted here, and a bayonet type forceps, which can be used to secure the throat pack down around the endotracheal tube. And in this manner then airway is secured. Going to some of the other instruments that you might not commonly be familiar with, we can look again at the Mayo stand, and we will see here several instruments that we will pick up. First, the Denhart mouth prop, which is a mouth prop used to spread the jaws, and it may not be familiar to you. The remaining instruments that are on the Mayo stand are the usual ones. Additional instruments may be seen on the back table, and over here there is an asepto syringe, which is a bulb on it and is used to irrigate with saline, usually, to flood the field and to keep things clear. Also, local anesthesia may be employed in a supplemental fashion, and if such anesthetic solutions are used, great care is necessary to make sure that the operator knows the content and that the anesthesiologist also knows exactly what is running to avoid any incompatibilities with the anesthetic solution that is local with the agents that are being administered by inhalation or intravenous method. We then would consider that this patient is completely prepared and draped and is ready for the operation.
Not all dental procedures in the hospital operating room are surgical. Restorative dental work can be done in this circumstance under a rubber dam. This affords additional safety since the patient under general anesthesia does not have protective reflexes. We must guard against the debris of amalgam and other foreign material that otherwise could be aspirated. In this way, large amounts of work can be done under the patient under general anesthesia, particularly in younger children or those that are handicapped by behavior or physical handicapping problems.
Let us assume now that the operation is finished and the patient then can be ready to react from the anesthesia. The operator will consider next the post-anesthetic recovery and will have to prescribe specific orders for this purpose. He will be helped out of his gown now that the operation is over, and we'll strip his gown. It'll be put in a linen hamper, and he'll pull off his gloves and look at the patient's chart and find the appropriate place to write the orders for the recovery unit, to which the patient next will be discharged. And we will next see our patient in the post-operative setting. Our post-operative visits to the patient may serve several purposes. We are certainly interested in seeing them as soon as possible post-operatively after they have reacted from the anesthetic to make sure that all of their needs are attended to. They also will require post-operative orders. These post-operative orders must cover all of their needs, because all orders that were written for this patient preoperatively are canceled when they go to the operating room. As a consequence, then, you'll have to repeat your orders that relate to diet, that relate to pain control, that relate to fluids, that relate to all aspects of medication must be then entered as postoperative orders for his care. So we will visit the patient. We'll try to cheer him up after whatever ordeal we may have subjected him to in his own interests, and hope that he's feeling reasonably well, and certainly inquire if there are any things that he needs additionally for his comfort. We'll examine him again. We would examine the area of surgery. We would make a progress note on his chart to this effect. Again, we'd accompany the patient with this chart. We would check on his temperature for the day. We would see what medications he's required. We'd review the nursing notes as to what needs he has had insofar as medications and other observations that the nurses have made about his well-being, his sleep, his relative comfort, and in that manner ascertain exactly his status. We may be watching his fluid and electrolyte balance with care as we find it recorded in the intake and output records of fluids. We will then make a progress note, appropriately dated, with our observations on it. We will continue to do this during his hospital stay. At the time of discharge, we will write a discharge note here. We will also write discharge orders for the patient, indicating that he is to be discharged, that he had, and write a note that covers the hospital stay. At this time, your responsibilities again as a member of the hospital staff are multiplied. If during this hospital stay there are any medical problems suggestive of serious diagnoses that need investigation, and these have not been investigated by appropriate consultation and laboratory determination and the like, you will be held responsible. Therefore, make sure that if there is such a condition, that appropriate consultation is sought and that this is resolved one way or the other before discharge. So if the patient is ready for discharge, you will indicate that and write the appropriate discharge orders. This will indicate when the patient is to return, perhaps to your office, at what time and the like. This is also a time where prescriptions are written for postoperative care, and they will be provided the patient as he leaves. The chart then has to be terminated or finalized, and in so doing, you would check for such things as an operative note which you dictated after your surgical procedure for him, and you would check that over to check on its content, and you would sign it. You would also note any pathology reports from biopsies or surgical specimens and initial them appropriately. The chart then is ready for a final summary, and in different institutions that is done in different ways. There's a summary, chart summary form in some hospitals. In others, a hospital summary is dictated covering the date of admission and discharge and the date of operation and all other things that related to that hospital stay. These are then finally signed out, and if you want to be a popular member of your hospital staff, make sure that your charts are up to date and that the record librarian isn't annoyed by your tardiness in attending to these matters. Well, we have covered then several of the things that relate to the concerns for our patients' welfare. Obviously, we try to cheer them up and try to minimize the difficulties of the hour and moment and suggest the prognosis is favorable and encourage them to be up and around and resuming as normal activity as possible so that their stay can be minimal and they can be back on the job as promptly as this is feasible. These are some of the phases then of bedside care, but before we leave bedside care completely, I would like to also use this opportunity to demonstrate certain specialized conditions of patients in a hospital wherein a different approach is required. These problems are namely those of infection. And herein, as a member of this hospital staff, precautions regarding infection in hospitals should guide your movements and approach to certain patients and patient areas. Infection is a problem in the hospital, and wherein patients contract infections, and these are noted in the form of infected wounds or other types of infection, efforts are made to keep them confined into rooms where these precaution signs often are outside of the door. Perhaps you may have been asked to examine a patient on a consultation basis who is confined under these circumstances. We would like to suggest to you the manner in which this can be done for your own safety and for the safety of the other patients in the hospital, so that we will not take organisms from the patient who is in this room to other areas of the hospital. Outside the door of such rooms, there will be a supply of gowns, masks, and gloves, which you will put on before you examine such a patient. You'll take off your coat and put on one of these gowns. These are always folded in a manner that the inside of the gown is toward you. You let them fall, and the inside of the gown then is clean. It's on, and you work your way into the armholes one at a time and tie the gown behind your neck, and also tie the waistband so that your street clothes are covered, and you will not then take infected material and organisms from this room in which you are about to enter. Likewise, airborne infection you would like to guard against yourself so that you do not become a carrier of this perhaps resistant staphylococcus that you could get in your own nasopharynx and spread from one patient to the other. After putting on the mask and gown, we then will glove, and often standard rubber gloves are used, or this type of disposable glove is useful for examination of this type of patient problem. These disposable gloves are made of very thin plastic, and you can, with care, insert your hand and get good coverage of the hands, so that be sure that you don't get any breaks in them, because they are here for a specific purpose, and that is to keep the organisms in this area and not carry them out. Therefore, we are now prepared to go into this room where the patient is in isolation and where you've seen this precaution sign, and we will enter with all body surfaces that will contact the patient or the bedside well protected. So we will then go in and examine this patient who has an infection. As we then enter this patient's room where there is infection and where these precautions prevail, all of our body surfaces that may touch the patient in the course of examining him, removing contaminated dressings, any contact with linen, bedclothes, and the like, these areas are protected. If we use any instrument on this patient who has this infection, it should be within that room. For example, if we want to examine his mouth, we have a tongue blade. This has been in this room. We will carry out our examination, and like the use of any instrument, again, as we would examine his mouth, this instrument must be discarded within the confines of this room and within this area. So there are receptacles within such a room for this purpose. They usually are covered, and they contain all instruments, and if other types of equipment are used, they are sterilized within the room so that no organisms leave by way of any vehicles, of instruments, without careful coverage and precautions. So after examining the patient, we now are ready to leave this room, and we will remove our mask, gown, and gloves and leave them within the room before we go back out to our street clothes. There is a circumstance in the hospital, too, where you may reverse this process of precaution by protecting a patient who is vulnerable to infection that you may bring to him. For example, the very ill patient, the one who has agranulocytosis, has no defenses against infection. You may wish to protect him and therefore approach him in this same covered manner, but not with the thought of keeping infected organisms within his area, but avoid bringing infection into him, similar to operating room precautions. So at any rate, we'll get back to this contaminated situation and the patient in isolation and on precautions. And now we're leaving after conducting our examination, and we will strip our gloves, being careful not to contact the inside surface of our hands with the outside of the glove. We'll discard the gloves, reach inside, and again strip the glove, discard it, untie our gown, and proceed with not touching the outside of the gown. Just grasp the inside of it, strip it out in a similar manner, holding only the inside, and then discard it in a hamper provided in the room. Again, the mask we would remove, and again only contact the areas where you haven't had direct air contamination to that mask. Then we are ready to leave this area, and we will not take any of this patient's organisms along to spread to other patients in the hospital.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.